So I don't know about you, but when I was a kid, we used to play this crazy game where we would stick our heads underwater and see who could hold our breath for the longest. I don't think any of us ever got past, 40 seconds to a minute. And I can remember how uncomfortable it was not getting oxygen. So I can imagine what our patients feel like when they're doing the same thing, where they can't get oxygen in or CO2 out. There is this individual named David Blaine who was somehow able to overcome that and hold his breath for over 17 minutes. But I can't imagine how uncomfortable that was. And we're not anaerobes after all, and we do need to intake oxygen and expel CO2. So we're going to talk about shortness of breath. Now, this isn't a comprehensive review of all the things that create the sensation of dyspnea, but this is supposed to be a review for COMAT or even the shelf exam, and what we think might be on those tests and how to approach them. So I'm Dr. Gavin Gardner. I'm a emergency medicine faculty member at OSU Medical Center in Tulsa with the emergency medicine program. I was lucky enough to have Dr. Alessandra Gerhardt, a pulmonologist at our facility, review this and give me some input, and hopefully the content reflects our effort and it's beneficial to you. So there are a lot of causes of dyspnea, and you can see from the list on the right there how many things create this sensation. But for the purpose of the test, we've got to make that list smaller so that we can compress the information and provide you with some meaningful education as far as taking the COMAT or whatever. So we're going to decrease that list to even smaller and focus on these two causes for dyspnea. And within the pulmonary cause, we're going to talk about foreign body aspiration and obstruction, pneumonia, pulmonary embolism, and asthma and COPD. As far as cardiovascular goes, we're just going to talk about congestive heart failure. At the end of this lecture, there'll also be kind of I call it a lightning round. We'll talk about some brief things that might also be on the test, but don't need necessarily a whole lecture devoted to them. So if you have a kid or you know a kid, you know how they like to put things in their mouth. These things that they put in their mouth sometimes make their ways to the airway, and therefore can be devastating. And they can be devastating for a couple of different reasons. First and foremost is that whatever that object is might block off the airway, creating an airway failure. Additionally, there's other things that can be swallowed or aspirated that have caustic properties that can create a whole slew of other problems, which we'll talk about. So some risk factors for foreign bodies and airway obstruction. Primarily, this is a disease of the young, for instance, the 1 to 3 year olds. But it can happen as we age, and dementia, in fact, is a risk factor for it. Also, neuromuscular disorders. So it seems like if we're at either extreme of age, where if we're old enough to lose our teeth or we're younger enough we don't have teeth, that's a risk factor for airway obstruction from a aspirated foreign body. Signs and symptoms shouldn't be any. This shouldn't be shocking. Cough, stridor, and wheezing. The one thing is, though, that this is typically abrupt onset because this isn't infectious, at least not initially. And so we don't have this prodrome of fever and things like that occur before. It's usually they were fine 1 minute, mom and dad turned away. The next minute they've got coughing and striding or wheezing. That's the patient you should think about a foreign body. As far as our evaluation goes, chest x-ray probably the most common test that we're going to order. Sometimes we'll add in an abdominal series too if we think this might be a swallowed foreign body. Unfortunately, the chest x-ray is normal in about half these patients. CT is another viable option, probably a little bit better in terms of imaging, but obviously associated with risks of radiation and other things. So chest x-ray, abdominal series usually are go-to tests. The bronchoscopy, however, is the gold standard for identifying these objects, and bronchoscopy also allows us to retrieve those objects. One of the favorite things they like to test on, it seems like, is to give you an x-ray of the chest, and there'll be a foreign body on the x-ray, usually a coin, and they'll want from the x-ray to determine whether this is in the GI tract or in the airway. So You can see in the upper right that X-ray shows a coin in the coronal orientation. Typically speaking, this is going to mean that this is in the GI tract. If it is like the bottom right X-ray where it's in the sagittal orientation, which you're looking straight down the edge of the coin, that's most likely to be in the trachea or the airway. So there's likely to be, or could be, a test question on those kinds of things, so you'd be familiar with that. However, if you look at the other X-ray in the middle, you'll notice that if you look closely that there's an outer ring and a circle in the middle. This is a characteristic of a swallowed or aspirated button battery. And these carry with them a whole different set of risks, because those button batteries can cause necrosis and perforation of the esophagus or the trachea. So those things have to be emergently removed. And, if it's a GI swallowed button battery, they usually won't go after it if it's left the stomach, but anywhere between there and the mouth, it's an emergent thing where the surgeons need to go in and remove that button battery before it erodes and causes mediastinitis. So we talked about how not all aspirated or swollen foreign bodies are radio-opaque, and therefore 50% of chest X-rays are negative. However, there are some findings that we can see on the chest X-rays that kind of give us a hint that a foreign body is the culprit for whatever the patient is presenting for. This is typically going to be on test questions, a child that has repeatedly shown up in the ER and they've been treated for croup or whatever it is. Finally, you get a chest X-ray and you see something like this. Well, because that foreign body is blocking the airway, some air gets in, but air is not able to get out. You get this hyperinflation of the lung. So the foreign body in this particular X-ray would be on the right. We see the hyperinflation there, and because of that, we have increased radiolucency, and all that pressure that builds up in that lung causes flattening of the diaphragm, and at some point may also result in mediastinal shift that we see here with that left mediastinal shift. Well, how do we treat these? Well, in the acute obstruction, it's as simple as the Heimlich maneuver, and this is a testable question as well, because sometimes we might forget about the basics. Also, back blows and chest thrusts. If we are able to, they should go to the operating room for bronchoscopy, because, like we said before, the operating room is the optimal place for that foreign body to be removed, and if need be, a surgical airway instituted at that point, if that's the only thing that is available to save that patient's life at the time. If they're unstable and dying in front of you, obviously we have to perform an endotracheal intubation. The idea here is that if this foreign body is lying above the carina, then it's creating a complete obstruction of the airway. We can insert an endotracheal tube and move that foreign body at least into the right main stem bronchus, and at that point we can at least ventilate the left lung and buy some time for the pulmonologist or thoracic surgeon to come in and remove that foreign body. So epiglottitis. Epiglottitis in the past has been a childhood disease. With the advent of modern vaccinations, we don't see it that much anymore. In the unvaccinated kid, in other words, a kid on the test that it presents with the right set of symptoms and they're unvaccinated, the bug is going to be Haemophilus influenza. In adults, it's going to be staph and strep. No shock to signs and symptoms here. Signs of infection, plus minus fever, things like vocal changes, whether it's hoarseness or muffled voice, drooling and stridor. And the way that we evaluate these kids, or adults for that matter, is a lateral x-ray of the neck, and we see that characteristic thumbprint sign that we see here on the x-ray that's on the screen, and that's how we arrive at a suspicion for epiglottitis. The treatment, antibiotics that cover for staph, strep, and anaerobes in the modern day, and vaccinated patient, things like ampicillin, sulbactam, piperacillin, tazobactam, clindamycin. We also administer steroids to try and reduce the inflammation, and then close airway observation. If these patients need to be intubated because of respiratory failure or impending respiratory failure, they should also go to the operating room because there is the potential, if that endotracheal intubation fails, they can proceed directly with a surgical airway. Also a very testable scenario there. Admission to the PICU or ICU. There are these entities that kind of resemble epiglottitis that we see, tracheitis and croup. So let's try and differentiate between those a little bit. Croup obviously being the most common. Winter months we see lots of croup. We rarely see epiglottitis or tracheitis. The etiologies of croup is going to be viral, whereas epiglottitis or tracheitis is going to be bacterial. The onset of epiglottitis is very rapid, whereas the other ones are much slower. The presentation of the patient, patients with croup and tracheitis are able to tolerate a supine position, but the patients with epiglottitis are going to present in that leaning forward, sniffing position because they don't feel like they can get airway in otherwise. As far as evaluating radiographically, the croup and tracheitis will have the steeple sign, whereas the epiglottitis will have that lateral neck x-ray showing the thumbprint sign. And then finally, in terms of treatment, croup responds very well to epinephrine, whereas the other ones respond less well or not at all. All right, so pneumonia. Pneumonia, extremely common in the ER. It is the world's leading cause of death among children under 5. And for U.S. adults, it is the most common cause of hospital admissions other than childbirth, and is the most common cause of sepsis and septic shock, causing about 50% of all those episodes. So something we certainly have to talk about. The kind of can be divided into a couple different flavors, if you will, but primarily bacterial and viral. The most common bacterial cause being strep pneumonia, of course, and then H. flu, Moraxella, Mycoplasma, Chlamydia pneumonia, and Klebsiella. Whereas the viruses, rhinovirus, influenza, adenovirus, parainfluenza, and nowadays we have to worry about COVID-19 as well. The chest x-rays for these different disease processes can give you a clue as to what you're dealing with. Where bacterial oftentimes will be a lobar presentation, whereas this particular x-ray shows kind of an upper lobe. You think about tuberculosis in that scenario, but either way, a lobar pneumonia, you think more of a bacterial cause, whereas a viral pneumonia on x-ray will have a lot more perihilar infiltrations. There's also atypical pneumonias that kind of have that patchy, fuzzy ground glass appearance throughout the lungs. Sometimes hard to differentiate between that and congestive heart failure. And also this is what COVID-19 chest x-rays oftentimes look like. Signs and symptoms, obviously tachypnea, tachycardia, shortness of breath, cough, chest pain. The way we evaluate these patients, primarily chest x-ray. And the patients that are young and healthy and are going to go home typically don't need any laboratory studies. There's a white blood cell count does not diagnose pneumonia. Chest x-ray and clinical scenario does. But if we are thinking this is a patient that may require admission, there are some decision rules or some helping decision-making processes that can help us. Those require laboratory studies. First, curb 65, you're going to have to get a BUN to adequately assess a curb 65. And the port score, you're going to need a BUN, glucose, sodium, hematocrit. For those patients, like I said, they're going home, chest x-ray is adequate. There's also some physical exam findings that increase the risk for patients having a bad outcome. Respiratory rates greater than 30, heart rates greater than 140, which should freak you out. Systolic blood pressure is less than 90, or diastolic blood pressure is less than 60. Fever greater than 101, altered mental status, obviously, and then extrapulmonary infections should also be something that makes you concerned that this pneumonia will require more attention. Dividing this pneumonias up into different categories and what antibiotics go with those categories can be a dizzy, makes you lightheaded kind of thing. You know what I mean? So this is how we initially divided things up. However, healthcare acquired pneumonia has kind of gone by the wayside. What happened there is that we ended up over-treating a lot of patients that needed just regular community-acquired pneumonia treatment, and so they said let's probably just do away with that altogether. It does probably still exist. We don't do that because of our over-treatment. So now what we have is community-acquired pneumonia, hospital-acquired pneumonia, and ventilator-acquired pneumonia. So with community-acquired pneumonia, this is a patient who has pneumonia, but no recent hospitalizations, obviously. Those patients who are low risk can be discharged with doxycycline or amoxicillin plus probably azithromycin. High-risk patients will require additional atypical coverage. Those patients are chronic heart, lung, or renal disease, alcoholics, cancer patients, or patients without a spleen. Those patients can get outpatient treatment with Augmentin and a macrolide like azithromycin. You can also use monotherapy with Levaquin. However, we're kind of trying to get away from fluoroquinolones because of all the side effects that are now known to be associated with them. Also, with macrolides like azithromycin and Levaquin, you've got to also be concerned about QT prolongation. These are antibiotics that are known to do this. So they should be avoided in patients with QTCs greater than 480 for sure. If this patient is going to require hospitalization, the antibiotics of choice are going to be things like Rocephin plus doxycycline or azithromycin. So hospital-acquired pneumonia, this is a patient that has gotten pneumonia after they've been hospitalized for 48 hours. Similarly, ventilator-acquired pneumonia is a patient who gets pneumonia after being hospitalized or after being on the ventilator for 48 hours. These patients have to be, you have to add coverage for MRSA and Pseudomonas. For MRSA, we're going to add vancomycin. For Pseudomonas, you've got some options, cefepime, Zosyn, Mirum, Levaquin. And if they're really sick, going to be in the ICU, we need to double cover for the Pseudomonas, and you've got your options. Double coverage, including maybe Levaquin and tobramycin in addition to one of the other ones. There's also aspiration pneumonia. Should be no surprise that alcoholics are a risk factor for these. Anything that causes you to not be able to protect your airway well, things like neuromuscular disorders, and then poor oral hygiene comes in here again. So this obviously, an alcoholic or someone with a neuromuscular disorder eats and they are unable to protect their airway and aspirate some food products and therefore have pneumonia. The common pathogens, still strep pneumonia is up there, staph, H. flu, Klebsiella, M. catarrhalis, M. pneumonia, and even anaerobes. With aspiration pneumonia, depending on who you read, some will say it's going to be a right-sided infiltrate, but some will say right upper low, right middle, right lower. If you see in a test thread a alcoholic who presents with fever, cough, shortness of breath, and a right-sided infiltrate, they're probably going for a aspiration pneumonia. Now, if it's a patient who comes in and it is a nursing home patient and the nursing staff there is suspected that they aspirated something today, the patient can come in with cough and things like that, but there is no prophylactic treatment for aspiration. So if they aspirated today, they don't get antibiotics. Not until the pneumonia declares itself, if it's going to, then that's when the treatment begins. Treatment can be ceftriaxone and Flagyl, ampicillin, sulbactam. If they're going to be orally treated, clindamycin, moxifloxacin. And if you're suspicious of a large foreign body or if there is concern that one exists, they can go to the OR for bronchoscopy, and the pulmonologist can remove large foreign body aspirations at that time if there's concern for that. Something else that's really testable is this kind of pneumonia plus scenario. So you've got pneumonia plus something else. It seems like these things always tend to get on tests for whatever reason. So current jelly sputum and bulging fissures plus on a chest x-ray, think Klebsiella pneumonia. If your patient on the test is around birds or bat droppings, or they like to spelunk in the caves, whatever, think histoplasmosis. This is a fungal infection, so it's going to require amphotericin or itraconazole as far as treatment. And then exposure to goats, sheep, or cattle, think of Q fever. Air conditioning, large buildings, Legionnaire's disease, alcoholic Klebsiella. Hunters, trappers, and campers, you think of tularemia, and the treatment there is going to be doxycycline. HIV or AIDS patients with a CD4 less than 200 present with chest X-ray, and they, bat, quote unquote, bat wing pattern. Honestly, sometimes it's kind of a ground glass pattern or even a negative X-ray, but on the test, they're going to be looking for something specific, so they might give you bat wing pattern in a patient with a CD4 less than 200. Think about pneumocystis urovetsii. And then if you patient with pet birds, think of psittacosis with, and the treatment, obviously, tetracycline or erythromycin. All right, so we look at this picture, and you go through all these things on the picture. These are all risk factors for something specific: surgery, oral contraceptives, smoking, hypercoagulability, cancer, pregnancy, travel. That's going to be risk factors, obviously, for the big clot in your pulmonary vasculature known as the pulmonary embolism. There are multiple risk factors for this. If you're this female who is a pregnant smoker who recently traveled from Thailand after elbow surgery, who has factor V and recently acquired COVID as well, as soon as she lands in the airport, she might as well get in a cab and go directly to the emergency department because she's most likely got a pulmonary embolism. But there's lots of risk factors. A new risk factor that we've discovered over the last couple of years, and thanks to Dr. Carahart pointing this out, COVID-19, I don't know if it's going to be on the test, but in the future it may be, is an independent risk factor for PE as well. Signs and symptoms, tachycardia, that's going to be the big one, tachypnea, hypoxia, dyspnea, chest pain, hemoptysis, syncope also. Syncope not necessarily a big one, but there's a study that's come out recently that's linked syncope with PE, so I can see that kind of being a test question. So tachycardic, syncopal patient, clear lung sounds, hypoxic, think PE for sure. So our tool bag for evaluation PE of pulmonary embolism, EKG, obviously tachycardia being the most common presenting there. Chest X-ray, typically normal, but there are some things that we can look for on the chest X-ray, or at least test-wise look for. D-dimer, it's a commonly used test, but it has some problems associated with it. CT angiogram, which is the go-to test, and then the VQ scan we'll kind of go over as well. As far as the EKG goes, S1Q3 T3 is the thing that they always like to put on the test, but it's rarely seen in real practice. But if they have a patient who has the right scenario, tachycardic, recently traveled, smoker, they give you the S1Q3 while they're looking for a pulmonary embolism. Tachycardia is by far and large the most common abnormality seen on EKG. Normal is still a possibility, but that's the most common abnormality seen on an EKG is tachycardia. And then we can also look for right heart strain with new right bundle branch block or T-wave inversions or ST depression in V1 through V3, maybe V4 as well. Those things are all indicative of EKG findings that you'll see with the patient with pulmonary embolism. Like we said, chest X-ray oftentimes is normal. You don't see anything on there. The tests love to talk about Hampton's Hump and Westermarck sign. Hampton's Hump being that wedge-shaped pulmonary infarct that you supposedly see on chest X-rays, but never really do in real life. And then there's that Westermarck sign, which is you get that you get the clot that blocks the blood flow, so you get proximal dilation of the vessels, and distally you get oligemia. Again, hard to pick up on X-ray, but they still love to test over this stuff, so be warned that that might show up as well. D-dimer also very testable, somewhat controversial. It is fairly sensitive with a 90% sensitivity, but so many things cause an elevation of the D-dimer that it's horribly nonspecific. The multiple false positives ranging from malignancy all the way to advanced age, including pregnancy, these things cause a false elevation of the D-dimer and can lead you astray as far as testing goes. The D-dimer really is designed for young, healthy patients who have a really low pretest probability of PE, and oftentimes the D-dimer gets used inappropriately. But still, lots of problems associated with it, still used considerably in the emergency department, however. Another thing that you can use, and might be on the test as well, is the PERC criteria. Like the D-dimer, this should only be used in those patients who you think are a low risk for PE to begin with. Those criteria: age less than 50, pulse less than 100, O2 sat greater than or equal to 95%, no history of hemoptysis, they don't use estrogen, they haven't had surgery in the last 4 weeks requiring hospitalization, no history of DVT or PE, and no unilateral leg swelling. If all those criteria are met, there's no additional need to pursue the diagnosis of pulmonary embolism because they have less than 2% chance of having it. So the VQ scan, you don't really see this utilized much anymore. It used to be that test that we ordered for patients suspected of having pulmonary embolism but had poor renal function and they didn't tolerate the contrast for the CAT scan. We're increasingly aware that the concern that we had about contrast-induced nephropathy probably not as big a deal as once was considered. And VQ scan is notorious for having inconclusive results. And 15% who have this low probability VQ scan that's been performed still have a pulmonary embolism. So with the advent of CAT scan and our understanding of contrast nephropathy, it's probably the death knell for VQ scans. I don't suspect there will be a lot of those in the future. CT angiography, obviously the diagnostic modality of choice. It is the gold standard for diagnosing PE. It also offers the opportunity to diagnose other things like pneumonia or mass or pericardial effusions and those kinds of things. Can also give us an indication on CAT scan whether or not there's right heart strain, which is potentially an indication for TPA use. So CT scan, by and large, the modality of choice for diagnosing PE. The treatment, obviously, oxygen, anticoagulation with heparin, low molecular weight heparin. Thrombolytics are not controversial, but who gets them and who doesn't get them can be somewhat controversial, and how we administer them. Obviously, on the test, if they're super unstable, they get TPA. There's also the question, do we administer it catheter-directed TPA? I don't know that will necessarily be a choice on the test, but I think for the most part, unstable patient gets thrombolytics, stable patient gets low molecular weight heparin or heparin, O2 and admission. There are surgical interventions for pulmonary embolism if it's a patient who can't tolerate anticoagulation because they've had GI bleeds or whatever, or they get recurrent pulmonary embolisms despite adequate anticoagulation. Those patients will have an inferior vena cava filter placed, also called IVC filter. In the emergent setting, sometimes these patients, theoretically anyway, will go for embolectomy by vascular surgery or thoracic surgery. Never actually in my years of practicing emergency medicine see that happen, but it's an option that apparently is available. There's all this discussion too about submassive PE versus massive PE, and you might think that that's a diagnosis based on the size of the clot, but it's not. It's actually how the patient presents. So submassive PE, right ventricular dysfunction, evidenced by CT, BNP. They've got EKG changes that suggest RV dysfunction, or a myocardial necrosis like an elevated troponin. These are patients that don't have hypotension versus a massive PE, who's a patient who has a systolic blood pressure less than 90 for 15 minutes or requiring inotropic support. They have obstructive shock. That's where the diagnosis of massive PE comes in. So things that look like PE but are not a PE. Fat embolism, this is like a long bone fracture, like a femur fracture, and now they present with PE-like symptoms, shortness of breath, hypoxia. That's fat embolism. Septic emboli from endocarditis. They have fever, new murmurs. We'll get into this a little bit more in just a sec. And then amniotic fluid embolism, that patient who just delivered a baby then suddenly has symptoms that look like a pulmonary embolism. And you look at this chest x-ray and you say, hey, what's the difference between septic emboli and an atypical pneumonia septic emboli from endocarditis? Well, with septic emboli, you find all these particular foci of infection on the chest x-ray, which you can identify. This is usually is going to be from endocarditis. You can use Duke's criteria to try and help diagnosis. The imaging modality for endocarditis is a transesophageal echo, also known as TEE. So if that comes up as a question, that's how you are going to diagnose it radiographically with a transesophageal echo. So if I told you the answer was albuterol, the question would be, how do you treat asthma and COPD? So these are both chronic inflammatory conditions, but there are some differences between the two. Asthma is large and small airways, where COPD is particularly small airways. Asthma is an obstruction primarily from smooth muscle bronchoconstriction, where COPD has that, but they have a lot of mucus production as well. And they also have tissue breakdown, a loss of elastic recoil. The asthma patients are hyper responsive to airway triggers. COPD is as well. However, they have different cellular responses that wind up with that hyper responsiveness. Theoretically, in asthma, airflow obstruction is fully reversible in asthma, where it is not fully reversible in COPD. There's often lung parenchyma destruction, and therefore, the COPD patients are not able to get back to the way they were before they had COPD. Asthma has a greater response to bronchodilators, and COPD has a less response to bronchodilators. The treatment of choice for both is still albuterol. We still use ipratropium for both, even though the anticholinergic effects of ipratropium are probably better for COPD than they are asthma. So asthma symptoms, wheezing. The test may say a kiddo with a nocturnal cough. That's a key word or key phrase that leads you to the asthma diagnosis, and obviously shortness of breath. The evaluation is primarily in the patient who has established asthma, just a physical exam. And now I say established asthma because if they don't have established asthma and they present with asthma symptoms, a kid that's young, no history of asthma, presents with asthma-like symptoms, that kid gets a chest x-ray. We call those first-time wheezers. They always get a chest x-ray. They don't have a diagnosis of asthma. Treatment, beta-2 agonists like albuterol, steroids, ipratropium. Remember that it is an anticholinergic medicine. And remember, for toxicology, anticholinergic, dry as a bone, hot as a hair, blind as a bat, red as a beet, and mad as a hatter. What we're looking for in the treatment of asthma and COPD is the dry as a bone, because we want to dry up all those secretions. O2, but only if they're hypoxic. If you're an asthmatic patient, if you have an asthmatic patient and their oxygen saturation is 95%, you do not administer oxygen because they don't need it. Only in the patients who are hypoxic do those patients get O2. If they're really sick, we can give continuous breathing treatments with albuterol. maybe epinephrine, magnesium sulfate to try and relax those smooth muscles, and non-invasive ventilation like CPAP or BiPAP. Heroic measures are also sometimes indicated like ECMO or Heliox, because Heliox lowers airway resistance and maybe bypasses that obstruction and allows air to get into the lungs. We really try not to intubate the asthmatic patients as much as we can, because there's lots of problematic scenarios that go along with intubating asthmatic patients. You can imagine we're shoving all this air down into their lungs, which can create barotrauma and subsequently pneumothorax. So we like to give them permissive hypercapnia. We keep their rate low. Whereas someone you intubate for some other cause, you might keep them at a rate of 10 to 12. The asthmatic's going to be lower than that, like a rate of 6. We're going to allow them to be hypercapnic, and we're going to allow them to be on the hypoxic side, because we don't want the barotrauma from all that air getting in. If you think about it, what happens is that particularly if your rate for the ventilator is too fast, you're shoving all that air into the patient, and then they don't have time for all that air to exhale because they've got asthma and obstruction from that. And then we're going to shove more air in on top of that incompletely exhaled breath. And so we get breath stacking, which can lead to hypotension and pneumothorax. So we really got to watch for pneumothorax in those patients as well. If you see a patient with a sudden loss of blood pressure and desaturation, you've got to really be concerned that a pneumothorax has occurred. The plateau pressure on the ventilator that we're looking to stay below is 30. So all these things very testable. The complications of intubating an asthmatic patient. There's also this mnemonic that for those patients who have a sudden loss of blood pressure, sudden loss of O2 saturation despite being on the ventilator. It's called the DOPES mnemonic. D for displacement, in other words, has the tube come out. O for obstruction, they can get obstruction from like a mucus plug within the tube, or maybe the tube is kinked. And then obviously pneumothorax, which we talked about. Equipment, like the O2 isn't hooked up to the ventilator, or stacked breaths like we talked about as well. And what you do there is you remove the ventilator from the endotracheal tube, press on the chest, and all that air is exhaled, and you've temporarily relieved this stacked breath problem. All right, some things that look like asthma that aren't asthma. Vocal cord dysfunction, congestive heart failure can sometimes even fool you, sarcoidosis, and foreign body aspiration. We talked about croup in kids. Asthma can also be that thing with a kid that is returning persistently to the emergency department. It doesn't seem like they're getting any better. In other words, maybe they get better while they're there and they go home, but then they come right back. Chest x-ray in those kids, asymmetric lucency or hyperinflation like we talked about before. You've got to be concerned about foreign body aspiration in that kiddo as well. So COPD, we said airflow obstruction, but is not fully reversible, unlike asthma. They also have structural changes, like the surfactant cells are replaced with mucus cells. They have a lot more mucus production. Causes include smoking, air pollution, and alpha-1 antitrypsin deficiency. There are also cardiac effects from COPD that you'll see. That chronic hypoxia causes right heart failure and subsequently distension of the atrium and can result in arrhythmias like atrial fibrillation. You have your typical blue bloater and pink puffer. I'm assuming they still teach it like that. Chronic bronchitis being the blue bloater, making up about 85% of COPD patients with lots of increased mucus production. And then there's emphysema, which is the pink puffer, that's about 15% of cases, and there's actually destructive disease and changing of the pulmonary anatomy. Just like asthma, wheezing, cough, shortness of breath, these are older patients typically, so we get a lot more chest x-rays on these patients. They have a lot more comorbidities than the younger asthmatic patients. They get pneumonia more frequently, pneumothoraxes, they get congestive heart failure, which we can sometimes differentiate on the chest x-ray from an exacerbation of their COPD. You have to be careful when you're looking at the chest x-ray though, because these emphysematous patients will often have these large bulli that look like pneumothoraxes, but they're actually not. So just something to keep in mind when you're looking at a chest x-ray to be concerned about. When they get EKGs, we'll often see right ventricular strain patterns and arrhythmias like atrial fib. They also have this pulmonary disease pattern, which is negative Q waves in the precordial leads that you'll sometimes see on the EKG as well. Treatment, inhaled beta agonists, steroids, ipratropium, like we said, is particularly more effective in the COPD patient. And then careful administration of O2 for hypoxia. There is that notion that COPD patients are hypoxic driven, not CO2 driven, and therefore administration of oxygen can diminish their respiratory drive. Something that's very testable, probably not as applicable in real world, but that's the kind of question they love to put on tests. Very sick patients, continuous breathing treatments, epi, magnesium, non-invasive ventilation, just like we did for asthmatics. When do these patients require antibiotics? Well, if they've had an exacerbation of their symptoms and they've had increased sputum production or change in their purulence, then those patients require antibiotics. Like asthmatics, we don't like to intubate these patients, but I can tell you that a lot more of these get intubated than asthmatics in my experience, and they typically do fine and don't seem to have the same level of disability or of problems on the ventilator that the asthmatics do. All right, let's talk about cardiac causes of shortness of breath. We know that I'm going to talk about congestive heart failure as being a cause. Acute coronary syndrome is a cardiac cause of shortness of breath too, but that's probably more a subject for a cardiac lecture than this. Also know that as we age, shortness of breath becomes more of a predominant complaint in acute coronary syndromes, and in fact, may be more important than chest pain. If you've got a 75-year-old patient who presents with shortness of breath, not only do you think of pulmonary causes, you have to think of that as being anginal equivalent, and they're having a heart attack. So there are lots of different terms that are associated with the CHF. For the most part, we're going to talk about just diastolic, systolic, and high output heart failure, but there's also, they talk about left-sided or right-sided, or preserved left function, LV function, reduced LV function, biventricular hypertension, hypotension, low output, well, whatever. All these terms about congestive heart failure, we're going to focus on the three, as I see it, main causes or main terms that define congestive heart failure. Basically, it works like this. In congestive heart failure, either the heart doesn't fill well, it doesn't pump well, or there's something else going on like high output failure. In diastolic heart failure, it looks like heart failure. These patients are short of breath, and all of the characteristics of heart failure. They're often hypertensive. They have normal ejection fractions, but they have this impaired feeling. What's happened is that over so many years of untreated hypertension, that heart is beat against such resistance that it's become muscular, and now it's hard to fill. So the way we treat those patients is by slowing the heart rate and hopefully thereby improving the filling of the heart and improving their output. That's done with beta blockers and calcium channel blockers. Then there's high output failure. This is the engine that is trying to pull and it just doesn't have enough to do it. It's for whatever reason, your body needs a lot more output, but it's just more output than the heart can generate, and that's what it results in high output failure. The ejection fraction is oftentimes above normal at 70-80%. Remember that normal ejection fraction is about 60 to 65%. So they have higher ejection fractions. Some causes of this are going to be anemia, hyperthyroid, burns, beriberi, AV shunt, sepsis, those types of things. The treatment is going to be fixing the problem that created the high output failure. So if they're anemic, give them blood. If they have beriberi, give them thiamine. And thereby we're treating the high output failure. All right, the most common cause of heart failure is systolic or low output. That's generally from coronary artery disease or cardiomyopathies. We talk about this in terms of left-sided heart failure and right-sided heart failure. Left-sided, they have shortness of breath, pulmonary edema, they have an S3 sound, orthopnea. With right-sided heart failure, they get JVD, hepatic congestion, peripheral edema, and then remember, left-sided heart failure is often the cause of right-sided heart failure. If they have sudden onset of right ventricular or a right-sided heart failure, you've got to think about a right ventricular infarct or pulmonary embolism. Those are causes of sudden onset of right-sided heart failure. Our evaluation, chest x-ray, looking for pleural effusion, cephalization of vessels, enlarged heart, curly B lines, those kinds of things on the chest x-ray. EKG, looking for signs of ischemia that's created this low output failure. Bedside echo, obviously they will get an echo if they're admitted to the hospital by cardiology, but we can also do a bedside echo to identify patients that we think have congestive heart failure. This might be beyond what the test is going to go over, but you're going to be seeing this used in the ER. Basically, you take your probe and across the mitral valve using M-mode, and you calculate this EPSS. You calculate this distance, and if it's less than 7 millimeters, it's a normal EF. If it's greater than 10 millimeters, it's a low EF. There again, not something that's likely to be on the test. I don't want to go over it extensively, but realize that when you're in the ER, you're probably going to be seeing this used, and so it's good to be familiar with it. Also, BNP, the laboratory test as an evaluation for CHF, we'll talk about how the pitfalls and problems and benefits of the BNP as a test. So BNP, if it's normal, it's not congestive heart failure. But moderate elevations could be congestive heart failure or something else like PE or RV infarct. And there's some kind of, that chart on the right there kind of goes through that a little bit. It's good if you can compare your BNP. You've got a patient that arrives in ER, they've been there before, you compare today's BNP to previous BNP. If it's a lot higher, that leads you down the path that this is an exacerbation of congestive heart failure. Treatment O2 only if they're hypoxic. Non-invasive ventilation like BiPAP or CPAP. Diuretics, nitrates. Remember, at certain doses, nitrates can reduce preload and afterload. Maybe we need to improve on contractility and fix the underlying problem that's created this systolic heart failure. You remember the unload me mnemonic that's kind of gone by the wayside. Morphine we don't use anymore. And niceratide was a medication that came out a long time, or somewhat recently, for the treatment of CHF. It's also kind of gone by the wayside. So if you see on the test question, BiPAP, CPAP, or niceratide, it's probably BiPAP, CPAP. So, all right, lightning round. Go through real quickly some other things that might be on the test. Hemoptysis, most common cause bronchitis, especially chronic bronchitis. Massive hemoptysis. In the ER, massive hemoptysis is when you walk in the room and say, oh my God, that's a lot of blood. But in terms of the test or otherwise, greater than 50 mils once or greater than 600 mils over 24 hours is the definition of hemoptysis. Most common causes being bronchiectasis, tuberculosis, or lung abscesses. The way we treat these is we put them in Trendelenburg. We try and put the bleeding side down towards the bed, and then we get on the phone and call pulmonology or thoracic surgery, because that's in the end how the problem is fixed. Maybe interventional radiology. So pneumothorax, there are 3 different flavors. This comes in spontaneous, secondary spontaneous, and iatrogenic. Spontaneous is those patients who go scuba diving, or the patient who was smoking marijuana, had this strong Valsalva, then they come in with chest pain and shortness of breath. Marfan syndrome, we all know what that looks like, the tall, thin person. Secondary spontaneous from COPD, pneumonia TB, neoplasms or sarcoid. Iatrogenic from patients who've been on the ventilator and received positive pressure ventilation. Maybe their pressure went up. This is what happens in asthmatic patients. Or we put in a central line and we went too deep and we popped the lung. Also from biopsies or thoracentesis, that's all iatrogenic. How do we treat these? Well, if they're small meaning less than 15 to 20%, we can give them oxygen, even if they're not hypoxic, because we change that nitrogen oxygen gradient and therefore improve the absorption of the pneumothorax. But oxygen and observe. You can also use a simple catheter to aspirate the air and then observe them. Repeat chest x-ray. The gold standard is the chest tube or the tube thoracostomy. We do that in large pneumothoraxes, large defined as greater than 25%. We can also put in nowadays pigtail catheters, but I don't know that it'll get into that too much on the test. It's basically small. You've got a couple options, O2 monitor. Large, they're going to get a chest tube. Tension pneumothorax, these are, traumatic from trauma or they're on a ventilator, like penetrating trauma. Those need immediate needle decompression. You have a strong suspicion of that based on your vital signs and your auscultatory findings. That person gets needle decompressed, and then they get a chest tube right after that. The reabsorption rate for a pneumothorax without oxygen is about 1.25% per day on room air, and about 5% per day if you put them on supplemental oxygen, high dose O2. So, how do you know whether it's a large pneumothorax or a small pneumothorax? Well, there's this complicated formula and measurements that you can do on the left, and then there's the ER way to do it, which you measure from the apex of the cupola of the thoracic cavity to the apex of the lung. If that's less than 3 centimeters, it's small. If it's greater than 3 centimeters, it's large. And that's simple, and that's how we do it. So inhaled gases, Seidelfeller's lung or Seidelfeller's disease, that's nitrogen dioxide pneumonitis. It has a bleach-like odor, and the symptoms can be delayed 48 hours in some cases to develop. Then there's hydrogen sulfide. You'll see that in petroleum industry, sewers. They have a loss of consciousness and death. I've actually seen this. OSU, right across the river from us, is a refinery, and so we've seen some hydrogen sulfide problems. Then phosgene gas, as from industrial accidents, it's usually from heating chlorinated hydrocarbons. Has an odor of freshly cut grass. They get respiratory distress, lightheadedness, nausea, vomiting. And then lastly, pleural effusions. Transient dates are lab-wise LDH less than 200. Their fluid to blood ratio is less than 0.6. Fluid to blood protein ratio less than 0.5. I don't even know what any of that means, but that's what's in the book. Congestive heart failure. The people have transient dates, congestive heart failure, cirrhosis, PE, nephrotic syndrome, peritoneal dialysis, and then exudates are from infection, neoplasm, uremia, pancreatitis, esophageal rupture, post-surgery or trauma, that kind of thing. So, one more thing, tuberculosis. Usually primary TB is asymptomatic, but they can have cough and fever, that kind of thing. Reactivation TB is what we usually see and worry about. Have cough, night sweats, weight loss, hemoptysis. And then they can also get extrapulmonary TB. That occurs in about 15% of cases. They can get it at lots of different places, like the pericardium, GI, just about anywhere. Skeletal, if it's in the spine, that's called Pott's disease. The way we test these, we get a PPD, which you probably had before working in the hospital, whatever, the skin test. We can also check the sputum for acid fast staining. Those two things are time consuming and take a long time. There is a blood test that's turnaround time is a lot quicker, the quantiferon gold. So a lot of us will use that now if we have concern for TB. Treatment, respiratory isolation, obviously, because we don't want this spreading. And then 4-drug therapy with isoniazid, rifampin, pyrazanamide, thambutol, or streptomycin. One favorite question they like to ask as well is about tuberculosis patients who present with seizure, and the treatment's you're going to treat the seizure like you normally would, benzodiazepines, but they're going to need pyridoxine B6 because isoniazid toxicity causes a B6 deficiency and therefore seizures. So TB patient, seizure, pyridoxine B6 administration to treat the seizures. All right, so hopefully you found this beneficial. I hope that this helps you and it allows for good scores and less anxiety about the ER test, and good luck to everybody.